Thank you very much, Ravi. It's a pleasure being here. I hope everybody can hear me. I'll be talking about something that I believe is the last frontier, prediction in healthcare. And the reason I believe it's the last frontier is because healthcare is, in many ways, with its regulation, whether it be the case that, for example, kudos to Google, where the physician actually listened to something that Google had to say. I have yet to have a physician ever listen to me. So it is the last frontier from multiple perspectives on how to get acceptance, how to get data, how to even get things connected, and ultimately how to even predict if you have the data. The reason it's such a big challenge is that healthcare is a massive little data problem. Let me explain what I mean by that. Let us say I have a lot of data on somebody, and I'm just going to pick on somebody. Hopefully you're not a frequent flyer at any health facility, but let's say I have 30 data points on it. Predicting the 31st is actually not that hard. What is really challenging in healthcare is to take somebody and have a single data point on, or maybe nothing. All I have is socioeconomic, some indicators, and based on that to predict that they're going down a bad trajectory, that they're going to end up in the hospital with 10 to 15 hours. That prediction task is very, very hard. It's very ultra-high dimensional, has many, many gaps, lots of biases, and is prone to overfitting in almost all healthcare applications. So, all right? Is this the way? There we go. So, the issue in healthcare is I find there are two camps. I've been doing healthcare analytics so long. There's one camp that believes I can predict anything. And honestly, if I could predict anything, you know what I'd be doing? I'd be predicting deaths in the long term and making a killing in life insurance. It's very hard when you try to say you can predict anything. It's also, there's the other camp, which largely is the people who did not want to do mathematics when they were young, who say, all this prediction is nonsense. I've been training for years, this cannot be predicted. And these two polar opposite camps live in their own worlds. The truth is very much in between. As long as you understand what is predictable, what has measured precision, what makes sense from a modeling perspective, there are certain things that are very much predictable. There's actually a very high volume of things in terms of value, monetary value, that can be predicted, and there are many edge cases where you should really not be trying to predict. The other issue with predictive analytics is that in many ways, the word prediction has been abused. Descriptive or summarization analytics is often sold as predictive analytics. And I'm going to show you an example where it really doesn't work. I can't just take what I've summarized and used in the past and say, that's going to be a trend for the future. That's traditional regression analysis, and all the respect to those who do actuarial science. This goes way beyond being an actuary. It's a precision actuary. It's a personalized actuary. It's to understand what's actually going to happen to you and you and you in the future. All right. So I've done enough of that. So the focus is not just population understanding, it's personalized. The understanding is not just high risk. Yes, high risk is easy. They're all in the ICU. It's predicting change in risk. And it's not I can predict at all. It has to be based on measured precision. It has to have an understanding what the underlying precision is. And I'm preaching the choir here. For people who have been in consumer, network, and everything else, you've been doing this for years. But in healthcare, this notion of measured precision is actually a little unusual. And one aspect that I want to highlight is that when you do unsupervised learning, some of the factors that really come into outcomes of patients, what do you think are the major factors? Obviously, the age, gender, the obvious indicators are there. But underneath the first primary indicators, some of the most important ones are who the physician is, who the provider is, where the provider went to school. If you can get the provider's GPA, it's also very useful. Because it is not just you going through healthcare. You're going through a chain of interactions with socioeconomic conditions, your family, everybody, but also all the different people taking care of you. And that can make a healthy patient sick and a sick patient healthy. You want the sick patient making a healthy trajectory, the healthy patient becoming sick to rarely happen, but unfortunately it does, because the provider doesn't know what the hell they're doing. This is a very complicated graph. But the trick in healthcare is to go from correlation analysis anybody can do, anybody with Excel can do, to higher order dependencies, which again many people can do, to causation, which is an art. But you never want to tell people it's causation. If you do, you're in legal grounds that you don't want to go into. But to get to causation, you want to be running a whole bunch of virtual clinical trials. You want to understand how you can do control versus what was actually done in terms of drug, whether it's BRX, whether it be claims records, whether it be labs, and to be able to differentiate them so you can say that this was likely causative. Again, it's an art, and there's different philosophies. But to get the causation, it's intervention being fed back to some very higher order behavior, ideally higher order tensor analysis, that then leads to everything that is machine learning, statistical deep learning wise. All right? Now, I put this up deliberately. These are actual patients with actual events, knee replacement. They had a knee replacement, and then they had various things happen, different colors of different events. Does anybody see a pattern? Do you see a pattern here? Anybody? Good. If you can see a pattern here, I should be out of work. It's impossible, near impossible to see a pattern here. There's too few data points. And what's more, they're all squished into 2D because I wanted a 2D time series. That is not the case. You have to understand which is the right dimension to embed this in. Only when you do that, can you extract out meaningful features that ultimately lead to predictability. Let me give you two examples. These are actual patients without real names. All the PHIs taken out. This is an actual patient with COPD. If you don't know what COPD is, it's a condition, chronic condition. Has hypertension. Doesn't always take his meds. We know the physician. We know the risk. This patient had a pattern that looks like this. This was the historical pattern. Okay? This is cost. This is time. And our engine correctly predicted, so did about 10 others, that he's going to have the pattern again next year. This was done in 2014, this is 2015. This is about 2 years ago, right? It was correct. Many of us predicted it. The prediction wasn't that high. The costs were high, right? And the intervention, it should have said home visit, is fairly effective. So you can actually pull out which intervention will work for this patient. This is not that impressive. We had it last year, it's going to happen again this year. It's a seasonal recurrence. But this is what is impressive. Here's a patient, 76-year-old, that's the right age, well-controlled hypertension. Reasons he'd seen for palpitations, but was otherwise asymptomatic. Physician said, you look fine, and sent her home. Real PCP, we know, risk score is low. She looks great. However, this is what is going to happen to her. We can predict it. That's the beauty of it. We can predict it. She is going to have a stroke. That stroke is going to cost $100,000. Very high. Okay? She is going to have severe cardiac arrhythmia. Okay? The associated costs are extremely high. And the intervention would have been as simple as to give her an additional medication. That one pill would have avoided this. So how can we predict it? Today, healthcare exists in snapshots. You go in there, the physician currently sees your lab, sees your prescription, says you look fine. Well, everything is within normal range. It is not where you currently stand. It is the trend towards where you were and where you're headed. Does it make sense? It's like a dam. You're below the red level, so what? It's going to rain 3 days straight. The dam is going to break, right? That is the beauty of it, is that these patterns, very little data. See how much data I had on them? Very little data is actually predictable. Now I'm going to show you the measured precision on this. These are the measured precisions. Okay, these are AURC numbers, measured on a 6-month window on a Medicare population of about 1 million people. I know the font is a little weak, but I hope you can see it. This is the relative accuracies with which things even like psychosis, in terms of AURC, can be predicted if you understand not just correlation, not just higher order dependency, and ultimately get to a point where you're doing enough intervention analysis to understand a degree of causation. Here are patients, these are actual patients, all fake names. These are the patients who were the supervisors. They cost a ton of money in the past. Do you see that? These are the patients. All the names are hidden, okay? All fake names. These are going to be the ones in the future. Between this one and that one, there's only 2 names in common. That's the beauty of prediction. You don't know. If you just use the previous list, you'll catch a few. If you're able to accurately predict with high enough accuracy who it's going to be, you'll catch a lot of them. And that's what will change what predictive analytics can do for healthcare. All right, so I have very few, just about a few minutes. So I'm going to quickly go into a case study. And I'm going to take people who all had surgery. In this case, I'm going to take a musculoskeletal event, like knee replacement. All of these patients had surgery, and they were all discharged. Some of them went to a skilled nursing facility as an inpatient, stayed in the inpatient rehab. Some went to skilled nursing, and some went to home health. Now, who went where is typically today fairly arbitrary. Here's a patient. Inpatient, got discharged home, stayed home. That's an ideal trajectory. The problem is this trajectory. Got discharged home, went home, shouldn't have gone home, ended up as an inpatient. That's a readmission. That's extremely expensive. It's bad for everybody. It's bad for the hospital, it's bad for the health plan, it's bad for the patient. Within 60 days, ended up back in the hospital for the same thing. So how do we do this? We have to optimize this trajectory. There's very few patients going that way. See? Very few patients going that way. But any patient going from home back is a bad event. It's bad for the whole system. It is to understand how each facility, how each provider, and how each patient interact in such a way that you understand how the risk changes with time. This is risk for surgical procedures. It changes with time, it's not a constant. How the risk changes with time. In different facilities, understand what that facility is good at. Some facilities are great at foreign risk, some are great at diabetics, some are terrible at cardiac patients. Understanding what they're good at, what they're bad at, what risk they can handle, what they cannot, and then optimizing the trajectory so that the best outcomes happen on a personalized basis. This is just an example. You can really micro-target, whether it's home health, whether it's skilled nursing, whether it's outpatient care, beyond inpatient care. You can really target based on that facility, that region, that particular person. What is the best choice in terms of costs and outcomes for them? So, just a little bit of time. I'm going to conclude. I believe this is the final frontier in prediction, that we have very little data to do a lot with in terms of being able to predict accurately, if we can get there.
So when you're talking about prediction, what information are you feeding into prediction model? Is it what you have in EMRs or something external?
Mostly claims, prescription, and lab data. EMR data is the hardest to get hold of in meaningful time. It turns out that it would be very beneficial to have EMR data, but the existing data sets, claims, prescription, and lab, are heavily underused. For example, when people look at labs, they look at HbA1cs, LDL, HDL. But a lab is a full spectrum. And you get to see everything in terms of lab values and how they change.
And if I may ask, you talked about precision, what about recall? You talked about precision of your predictions, what about recall? How many cases can you actually find?
It really depends on each particular case. So we have measured in some cases. So in many of these applications, they're not clinical in nature, they're more operational. So we are ultimately determining which entity to contract with to send traffic to so that you have the best use of resources for that facility. So if you were clinically used, So clinical decision support is one thing you could do with it, which I think has potential. But the biggest savings and the biggest value is in how do you do operational and logistical support with it. How does the CFO plan out how to allocate in such a way that they get the best treatment for the least amount of money?
Two questions, just at a high level. How do you see healthcare insurance reacting to this? And could it backfire on patients that are predicted to be too expensive?
So it's interesting. Because of regulation, the advantage of existing regulation, and things may change with time, is that there cannot be a selection bias in enrollment. However, health insurance is extremely interested in taking each of their enrollees, literally at the point of enrollment, and marking them as red and black. Am I going to make a profit here, or am I going to make a loss? So they're very interested in it. Now, they cannot officially have a selection bias. However, they are most interested in patients who are the sickest but don't come in. I'll explain why. A very sick patient ends up through the different systems because it's risk adjusted to give them the biggest amount of money paid in. But if their sickness is well controlled, they do not come in and do not cost them as much money. So what has happened, in the olden days, when everything was fee for service, the best situation was to sign up somebody young and healthy, like you. Today, the best situation is to sign up somebody that is a 75-year-old, chronic kidney, chronic this, chronic that, chronic this, chronic that, because the government will give you a huge check for them, and hopefully you'll send them home, send a nurse home, so that they never come into the facility and don't cost too much money. Does that make sense? So that has changed. All right, I'm happy to take more questions offline as well.
Next up we have Anil Arora, who's the president of